Hello and welcome to the recall session of November INI-CET exam for the subject of prosthodontics. I am your mentor, Dr. Ruchi Raj. Let us begin discussing the various questions that were seen in this time's November 2023 INI-CET exam. We begin with the first question here. What would be the best design for Pontic in this particular case? Now, this is an image-based question. And I, although have always stressed upon and always tried to even guide our students, Pontic is a very important topic. The same has been reflected here. Pontic is an extremely important topic for the exam point of view. This time from Pontics, we see an image-based question. Last time in the May 2023 INI-CET exam, we also saw an image-based question in Pontics. But generally, what we have covered in all of our sessions till now and how much we have stressed upon Pontic is a very important topic. And I hope all of you have gotten it correct. So let's come to the image here. It is asking the best design of Pontic in this case. Now, as you can see, this looks like a fresh extraction socket. As I can understand, it looks like a fresh extraction socket. You can see even the papilla. What I have seen in the exam is some amount of midline space was also present here. So generally here, when a fresh extraction socket is there, the correct answer becomes ovate Pontic. Ovate Pontic becomes our correct answer for this particular situation. When we have a fresh extraction socket, our choice of Pontic becomes ovate Pontic. The reason is that the ovate Pontic will condition and shape the tissue. So it shapes the tissue according to, in the healing process, according to the undersurface of the Pontic. And when that happens, you have a excellent emergence profile. Emergence profile, what does that mean? If we look over to the natural tooth, can we all notice how the tooth is emerging out of the gingiva? This is called as the emergence profile. So with an ovate Pontic in a fresh extraction socket, when we use the Pontic and the undersurface is convex, but the way we place it or we deliver it into our patients, it will condition the undersurface or the tissue surface in the region of the missing tooth in a manner that it would look somewhat like this. And when the Pontic is present there, it gives an appearance as if it is emerging out of your extraction socket. So that is the indication here, and a very clear-cut, easy question from the section of Pontics. I will still stress over this particular topic again and again, even when we talk about it later on also, maybe before next INI-CET exam. Pontics from FPD, I remember making a statement, if you want to read one topic from FPD, read Pontics, because these are cash marks for you, right? So very good question, very easy question also. Even if something tougher is asked from Pontic, we have covered everything. I'm sure all of you would have gotten it correct. So the answer here, ovate Pontic. Now, during application of soft liners under complete denture, the pressure on the basal seat should be what? First and foremost, we see the question here. What does it say? During the process of application of soft liners. Soft liners are your tissue conditioners. Nothing has been mentioned here, whether they are temporary soft liners or the permanent heat cure ones. During the application process of a soft liner, what should be the pressure on the basal seat? Should it increase? Should it decrease? Should it be unaffected? Or it depends on the resiliency of the basal seat with tissues. Now, this here is a repeat question. It is a repeat question. It has been asked before and it is there in our question bank also. The correct answer is unaffected. Now, the role of soft liner is that for all of the tissues that are abused or the tissues where you see the support is minimal or the soft tissue over it is friable in nature or the ridge is knife edge, in all of these situations, when we want a cushioning effect under a denture, at that particular point, we use a soft liner. There are categories as well as material. Also, different variations are available for soft liner. However, that has not been mentioned here. But what we see is asked is, during the application process of softliners under the complete denture, pressure on the basal seat, it should be unaffected. Usually what the function of softliner is that when you apply it under the denture, it acts like a cushion and it dampens the amount of forces that are transferred during function to the underlying tissue. So that is how it should be. And the correct answer for this question is unaffected. That is option number C. Another very simple question here. What type of finish line is given in an all ceramic prosthesis? Options are A, chamfer, B, shoulder, C, shoulder with bevel, and D, knife edge. Now, with your all ceramic prosthesis, what are we talking about? We are talking about prosthesis like your lithium disilicate, lucite-based prosthesis. In simpler terms, a lot of you are familiar with the word EMAX prosthesis. That is called as an all ceramic prosthesis. And the answer here is your shoulder margin. With an all ceramic prosthesis, ideally the most preferred indication is shoulder. Shoulder with a straightforward all ceramic prosthesis is the simpler answer. Metal prosthesis or a metal restoration will usually go for a chamfer. Knife edge, ideally, we do not prefer because it is very thin. The chances of wrong preparation are also there. But usually what happens is when we have a lingually inclined mandibular molar, sometimes we are not able to give a proper finish line over there. And the one that is prepared is a knife edge prosthesis. And we usually duplicate it in metal only in the restoration. But generally for your all metal restoration, we would prefer chamfer. Now, the doubt here arises in a lot of students' mind whether we should go for shoulder or whether we should go for shoulder with bevel. What should be the correct answer? If we go into the indications in our textbooks, it has been written on the facial surface of metal ceramic restorations for maxillary posterior, you can prefer shoulder with bevel. Also, in all those restorations where there is all those teeth or tooth preparations where we see significant caries or loss of tooth structure, or already you have seen that it is a old tooth preparation and you're re-preparing it and there is a wide margin present, or you see a lot of unsupported enamel. In that situation, the specific indication is there of shoulder with bevel. But when we are given a question like what type of finish line is given in all ceramic prosthesis, it is not that shoulder with bevel is not used for all ceramic prosthesis, but here what my understanding says is that when we are choosing something that is applicable to all or most of them, we have to choose some answer which is applicable to at least 70 or 80% of your general cases. So in 70 to 80% of your all ceramic cases, or generally what we know that for a porcelain restoration or an all ceramic restoration, we require a straightforward shoulder as our finish line, right? Whereas beveling is done in all of the cases where we have unsupported enamel. Now, we need to think to ourselves, is it so that in all cases of all ceramic prosthesis, we need beveling and we need shoulder bevel? No. But in most cases or almost all cases of all ceramic, we will at least go for shoulder and then add an bevel if necessary, right? So in my understanding, the best answer, considering the question which has been asked, what type of finish line is given in all ceramic prosthesis, I suggest very strongly we should go for the answer option B, which is shoulder. At this point of time, I want to take 2 minutes away from the question and would like to explain a belief that I have while answering MCQs. This is my method of solving MCQs is when I read a question, sometimes a lot of students have a confusion that 2 answers are correct or 3 answers are also correct in the 4 options that are given. What should I do? In such a situation, remember, it is possible that multiple options may be correct for the particular question. What you need to do is find the best possible answer for the given question out of all of 4 options. That is how we tackle all MCQs. Is it so that for all MCQs that you see, you will always get one answer and all other three options will be straightforward wrong? I don't think so. That is generally possible. Even while framing MCQs also, it is not possible. So what do we do? In such situations, what we do is we select the best possible option. So keep this in mind while solving your MCQs. We need to select the best option of the all four options. Whenever we do, always select the best possible option out of all four options, because that will be generally your answer. Considering this, let's move ahead to question number 4 here. I think, sorry, there is some numbering mistake. This is question number 4. What is the first sound spoken by a child? Now, again, a topic which I think I have stressed a lot upon while teaching through live classes, through recorded, through your TND, through any other most important INI-CET and NEET sessions on YouTube, or generally also speaking about prostho and the kind of trends that we see in prostho. Was one topic that I used to stress a lot about was on phonetics. Another topic which I used to stress a lot about, and I've spoken about it very recently in our T&D discussion also, is phonetics in complete denture. Now, the general trends that we have seen over a period of time is that with complete denture, conceptual as well as difficult questions can also be asked. And although phonetics is not considered very important, if we see from your university exam point of view, when you are a final year BDS student, phonetics may not be asked to you so frequently. But I think it is a very, very, very important topic considering your exam point of view, MCQ exam, right? And as we teach it to all of you, it is never previous year questions, but usually previous year topics are something that are repeated through your paper. So when I evaluated all of these questions, I received a bunch of questions, and then we had to correct a lot through them to bring this presentation through you. What I felt was the entire bunch of questions comes from the same topics that we used to stress on. They were phonetics, they were your finish lines, and very similar questions what we used to stress on. So generally, I found this a very predictable set of questions pertaining to prostho in this exam. If I were a student who has followed these trends and paid importance to them, I would be at least able to solve 90 to 95% of these questions. So coming to the next, that is, what is the first sound that is spoken by a child? Is it a monolabial? It is a bilabial, linguo-alveolar, or labiodental? Now with phonetics, I will give you one tip. Try to speak up those sounds by yourself. It helps you to come to an answer in a better way. Now we generally know that a child usually starts speaking ma, 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 pa, 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 ba, ba, ba. These are all of the sounds that a child starts speaking, and these are all your bilabial sounds. So bilabial sound means where the two lips are meeting. So pa, ba, ma. If you see pa, ba, your ma, ba, 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 ma, ma, pa, pa. These are all of the sounds that a child starts speaking. So if by your general life experience also you know that these are the sounds that a child starts speaking, you can just try them out and see what structures are touching. And that is how the naming of these sounds also happens. Labiodental, linguo-alveolar, that is how these sounds are there. Monolabial is not something very relevant or correct also. So the correct answer here in this particular question is our bilabial sound. Bilabial sound, pa, ba, ma. These are the sounds that are spoken first by a child. Now, the trend of phonetics in complete denture was regarding anterior teeth arrangement or anterior teeth placement. Regarding I would say linguo-alveolar sounds were asked a lot. Something about fur, ver, ter, fur, ver is something, when will fur sound like ver? When will ver sound like fur? That is like an age-old repeat question that has been continuously still asked. Now I see it has, the focus has shifted from that to bilabials here in this particular exam, but generally This is something that all of you should know. Phonetics in complete denture. If you're preparing for your exams, please pay good attention to phonetics. Question number 6 here. Which of these is true about the prosthesis shown in the image below? And what I have got as an understanding here was that you had a Kennedy class 3 modification 1 space, and you had maybe a clasp on the anterior abutment, and something was there. But what they were generally asking you was that what I have seen as the recall was a ladder type minor connector was present, a ladder type of minor connector which was present in the region of denture base, and that was present in the image. Rest all options that were given were not coinciding correctly. The recall that I have got to understand is that there were either restorations on the anterior or posterior tooth, and there were some sort of clasp assemblies, but they were not matching with the correct option. And the correct answer to this question was a Kennedy class 3 with a ladder type of minor connector. Now, if we classify this particular exact photo, it becomes Kennedy class 3 modification space 1, because one side or on the other side, both, it is a tooth bound space, it is a Kennedy class 3, and you have your one modification space. Now we look in this one particular situation. If we just generally see, this was our answer. If we generally see, this is what, sorry, just omitted the text. This is Kennedy class 3 modification space 1. Now, in this particular situation, if we see, and if I have to design this case, what I would give would be a circumferential clasp here. We can go for a circumferential simple circlet clasp. Same at this point also, a circumferential clasp at the posterior tooth. And since this is a canine, I would prefer either RPI or any other infrabulge clasp. So this would be my C clasp. This would be my C clasp. This again would be a simple C clasp, and this could be my RPI. I'm designing the particular case at my hand. And I can prefer to actually give a meshwork here in the region of the denture base, because these are tooth bound areas. You could also give a ladder here also, a ladder type of minor connector. Now, say you are in a similar situation as me and you don't have an accurate recall of a particular question. When I was a student and when I used to go through these papers immediately, especially considering that these questions are important for the upcoming NEET exam also, I used to get very anxious seeing I don't have the correct question. What would I do if the same question comes in the exam? I will help you through a solution for it. If you have a 40-50% idea of what the question was, try to understand that particular question, what it is asking, and the topic, and read little bit around it. So for this particular question, I give you an example. If you remember that it was a Kennedy class 3 situation, and there was something that was pertaining to the designing of it or components of it, I will just open up how a Kennedy class 3 arch in maxilla and a Kennedy class 3 arch in mandible is designed. What are the common clasp designs that are used, and which kind of minor connector is used, which kind of major connector is used, and generally brush through some of these photos from my standard textbook like McCracken or Stewart. The advantage it gives you is that when the same question gets repeated in your next exam, now you're thorough with the knowledge pertaining to solve the question. So consider it like a fresh question only for yourself. And if you have the knowledge, then you can always solve the question. Supposedly, if something different is asked from the same image, again, because you have read slightly beyond it, then is what is asked in the question, you would be able to answer it. So this prepares you in both of the situation. I, as a student, have done a lot of wastage of time, especially this crucial time between your INI-CET and your NEET exam, in solving controversial questions, Worrying about controversial questions, worrying about questions where I did not have a correct recall, and then thinking, if the same question comes in NEET, what will I do? Remember, any exam is made of 19 subjects. Those 19 subjects are made of 3 or 4 different sub-subjects or subspecialties. And this question is a part of one chapter of such one specialty. The chances of the same thing coming in your exam are less. But even if it comes, just take 1 or 2 hours from your day, try to read around the topic very briefly and superficially in the line of what is being asked. So, in the line of this question, what is being asked is designing. So, I will have a look at designing of Kennedy class 3 and class 3 in maxilla and class 3 in mandible, and just shut the topic, and whatever happens then you can deal with it in the exam, right? So that is my strategy after years of experience and understanding how to best utilize your time. So presently I don't have an accurate recall of this question. However, if you do remember, put it in the chat box, I will solve it for you, and we can have a better understanding of the question again also if necessary. So this is my answer according to the recall that I have gotten for the exam, that the correct option was ladder type minor connector, which was shown in the region of denture base. Now, how your ladders are, very briefly, I'll tell you. Ladder looks similar to a ladder. That is why it is called as a ladder type minor connector, or it is called as a lattice type of minor connector. It has a horizontal strut of metal like this. And in the mandible, if say this is your tooth anteriorly and this is a pad area, it covers only 2/3 of the edentulous area, and it does not go till the extent of the complete pad area. Only covers till the 2/3 of the edentulous region. Whereas in maxilla, it covers it fully. With lattice, you have the best bond with acrylic. Remember always, the best bond with acrylic is usually with the lattices. And just as an informal point that I can tell you is, lattices clinically we usually prefer in mandible, and we prefer meshwork more in maxilla, just for the sake of convenience and sometimes convenience of arrangement of teeth. That is just an extra informal point, not a theoretical point as such that you see in textbook, something that is clinically relevant. So that was this question. Coming to the next question, a very straightforward question. What is curve of Wilson? Is it an anterior-posterior curve? Is it a curve where posterior teeth are out of occlusion? Does it signify inward inclination of posterior teeth, or is it none of above? Now, when we read compensating curves for the balanced occlusion, we need to understand curve of Wilson. The best option here is represents the inward inclination of your posterior teeth. So this becomes your answer. As again with the previous question, if you students have a better recall of this question, please put it down in the chat box. Or for any other question, if you feel that you have a better recall than what I have mentioned, put it in the chat box. I'll compile it and I can share the correct answers in a better way that can help you for your next upcoming exam. Now, curves are present in natural dentition. Curves simulating them are called as compensating curves. And compensating curve for curve of Wilson is given in your dentures. It suggests your inward inclination of your posterior teeth that are aligned to it, and it is a mediolateral curve. It is not an anterior posterior curve, which means you can see it in your frontal plane, not your sagittal plane. So you can view it in your frontal plane, and it is a mediolateral curve like this and not an anterior posterior curve. Teeth that are arranged aligned with the curve of Wilson suggest the inward inclination of your posterior teeth. So that is our next question. Completely edentulous patient has bilateral buccal exostosis in the tuberosity region with an undercut above them. Which of these things will you do for your complete denture fabrication? Do you give relief to both of the undercuts? Do you keep both to help in retention? Surgical excision of one exostosis and surgical excision of both exostosis. Now, as a prostho mentor, I think if I have to pinpoint from complete dentures, which question comes as the most doubt question in any forum for solving prosthodonts is this question pertaining to maxillary tuberosity. My understanding and how I have taught our students also is that understand the logic behind it, and then whatever represents better in the question that is asked in exam, solve it likewise. In questions like these, remember, they may not be straightforward repeat questions. You change two words here and there, and everything changes in such a situation, right? So this present question, they have very specifically mentioned it has bilateral buccal exostosis. When you write exostosis, it means it is a bony outgrowth. And when you have a bony outgrowth, in relation to that, we have an undercut which is lined by a hard tissue like a bone. Now, nothing has been mentioned regarding the medical history of your patient, as well as a very important point, which is the size of the exostosis. Now, if it is a very small exostosis, we can actually try to give some relief and make a denture. But since you have bilateral, that means on both of the sides, it completely depends what decision you want to take on the size of the exostosis, and secondly, medical history of your patient to see whether surgery is possible. Given the choice that nothing has been mentioned in the question and we are left to make a decision on the only word, which is exostosis and bilateral, I would prefer to go for actually surgical excision of both of the exostosis, not completely but partially, and then go further with the CD fabrication. Now, try to hear my logic in this particular situation is what? When we have a soft tissue undercut, which is unilateral, we try to block it slightly, or we change the path of insertion of the prosthesis and try to negotiate it, because undercuts mechanically help with retention. When we have a soft tissue undercut bilaterally, what we do is we try to block one completely and utilize the other side, or we try to correct it on one side through any surgical means and utilize the other side for retention. When we have a bilateral hard tissue undercut, right, something because of an exostosis, my decision completely depends on the size of the exostosis bilaterally, not just one side. Here it has not been mentioned. Then my preference would be to go for surgical excision of both of the exostosis. The reason is, if I just excise one exostosis and the other one is also very large and you cannot change the path of insertion to tilt it and insert the prosthesis and utilize it for retention, that means then that treatment plan is very variable and different also. So in that situation, the treatment plan goes wrong. So what can be generally applied safely and what can be executed and be given a better alternative to the patient would be option number D, surgical excision of both exostosis. So my correct answer in this question would be surgical excision of both of the hard exostosis, or rather the bony outgrowth that are present. A lady comes with a discomfort and difficulty in chewing with a complete denture. Which of these cannot be a reason for the same? The question says, what cannot be the reason for discomfort and difficulty? So when reading this question, I have to keep it in mind. I have to identify the causes of difficulty in chewing with a complete denture and discomfort with a complete denture. Now let us see one point. Increased vertical dimension definitely leads to difficulty in chewing with a denture. Wearing of the moving part of articulator. Okay, let us see whether it does it or not. Incomplete closure of flask during processing. What happens is that when you have an incomplete flask closure, it leads to increase in vertical dimension, and increase in vertical dimension contributes to difficulty in your chewing. And impression errors. When you have an impression error, it will lead to discomfort of your patient for wearing a denture. So by exclusion also, answer that becomes here is what? wearing of the moving part of articulator. So the moving part of articulator, I assume, is the ball of the articulator, and wearing of the moving part of articulator will lead to more of occlusal errors because the casts are maybe shifting or not staying in the same relationship in which it is mounted. So it can actually lead to more of occlusal errors rather than it will lead to other problems also. But the chief problem there would be occlusal error. So according to me, the correct answer here is your wearing of the moving part of your articulator. Now, next question, what was asked in exam was an image-based question, and it was told to identify what is being shown here. And from this image, it is a very straightforward question from a partial dentures, removable partial dentures. The correct answer is option number A, altered cast technique. Dual impression, selective pressure, mucocompressive, all of these are wrong. Now, altered cast technique is a technique that is used along with dual impression, or rather, after dual impression has been made in the cases of removable partial dentures, which are Kennedy, class 1 and 2. So all of your distal extension cases where you want to record the tissue in the functional state and tooth in the anatomic state, you have to make a dual impression. After making the dual impression, you want to take the functional impression back to your original primary model which you had. So there you use a technique to alter the cast, which is called as an altered cast technique. In the first step of altered cast technique, what you do is you section the tissue portion out of the cast because it has been now newly recorded by functional impression. Then you can attach your impression or rather seat your framework, which is having an impression attached to it. As in the denture base will be, sorry, the tray will be attached to the framework and you've made the impression with the framework. You can seat your framework onto the model. Then you can do something which is called as your beading and boxing, and lastly pour a cast. So since you're altering the original cast by this technique, it is called as an altered cast technique. Again, a very straightforward question here. Now, supposedly you don't know what is happening. From the look of the image also, you can identify that something is being changed about the model here because the model has been sectioned and trimmed. And by beading and boxing also, you can figure out that a new model has been poured. From this much information also, sometimes we can take a calculative guess of answering altered cast because all three are impression techniques, other all three of them. So by exclusion also, you can come to the correct option, which is your altered cast technique. Now let us come to the next question, which is question number 13. A complete denture wearer patient develops a habit of biting and chewing from the anterior teeth only. What will be the effect? Will it lead to atrophy of anterior maxillary ridge? Will it lead to resorption of anterior maxillary ridge? Will it lead to flabby tissue in anterior maxillary ridge? Or will it lead to atrophy of posterior residual ridge? Now, my dear students, I'm asking all of you, if you have a better recall of this question here, please put it down in the chat box. This is a question very similar to combination syndrome, or it is also called as anterior hyperfunction syndrome, where when the patient bites from the anterior teeth, there is a possibility of starting the same cycle as your combination syndrome. And you see a lot of these things that are mentioned in the options here. And option number A and B mean the same only. Whether it is atrophy or resorption, it means the same. Now, my understanding says that these may not be the correct options and we are failing somewhere here in getting a better recall. So I ask all of you to provide me a better recall of this question. But in a situation where I assume if this was the exact question, I would go with option number C. The reason is that atrophy of maxillary ridge or resorption or atrophy of posterior residual ridge is not specific. It can happen due to a lot of reasons. But when the patient has an anterior hyperfunction syndrome, a flabby tissue formation in anterior maxillary ridge does happen, and it happens because of the combination of the hyperfunction syndrome. So my correct answer in that situation will be option number C, which is flabby tissue in anterior maxillary region ridge. Question 14. Guiding plane helps with what? Again, very straightforward question from removable partial dentures. Option A, predictable clasp retention. Option B, increases the resistance towards horizontal tooth movement. Option number C, transmits the force along long axis of the tooth. And option number D, provides a path of placement. A very straightforward question from partial dentures. Guiding planes provide a single path of placement, prevent unnecessary trap formation of foods, and help with a single path of placement and seating of your denture. So very straightforward question. It has been taught through our lectures. Very simple question that is even pertaining to definition and functions. That is question number 40 from RPD. And last question that is there in this presentation is, for gingival retraction, how much percentage of aluminum chloride is used? 1, 4, 10 or 2. So the correct range for aluminum chloride is considered 5 to 10%. So my answer here would be option number C, which is 10%. Again, a numerical question, straightforward question from your FPD. And this concludes our recall. This concludes our recall here for prosthodontics. Now, as your mentor for these subjects, I request you, if you have any more questions which we have not included here, please put it down for me and our team to get back in the chat box in the video that you see here. And if you feel any options were different, again, please help us out here. As these exams are recall-based questions, you may be able to recall some question better, and you might not be able to recall some questions at all. After all, human error is always there with these questions. And when we do recall sessions, I need to bring forward one very important point to all of our students. All your past papers are recall papers, and they are not directly obtained after the exam. These answers and questions are based on our recall and understanding. So take sometimes controversial questions with a pinch of salt. And probably if you're very anxious or doubtful about that, just read the topic around it and just pray for the best. If it comes in the exam and if you have sufficient knowledge to answer it, take it as a new question and answer it there and there in the exam. With this piece of information, this is me, Dr. Ruchi, signing off here. If you have any doubts, you can always ask us all your doubts on our DBMCI MDS group on Facebook and Telegram. We are always there to help you and wish you all the best for your exam results. Bye-bye.